Good evening and welcome to Hope for Healing. I'm your host, Dr. John Stracks, joining you from my office here in Chicago. I'm a physician who focuses on the reduction and elimination of physical symptoms using mind-body medicine methods. If you'd like to learn more about my practice, our therapists and I do practice telehealth, and my staff will be happy to talk with you. You can find more information about our services at www.drstracks.com. This Hope for Healing videocast series is one of many joint efforts between me and the folks at Curable. For those who are not yet Curable users, Curable is an amazing app that offers science-backed techniques for chronic pain recovery. They and I have been working together for about 6 years now, and we created this video series because we want to help people in pain understand the connection between what's happening in their lives and what's happening in their bodies. Tonight, my guest is Charlie Merrill, a physical therapist in Boulder, Colorado. Charlie is a strong proponent of working with the mind as well as the body to promote healing. And he believes that we do a disservice to people in pain by making the diagnosis about either the mind or the body and not about both. So a big part of his mission is helping people reduce fear, get back onto their feet, and get back into their favorite activities. Charlie, thank you so much for joining me here tonight on Hope for Healing.
Thank you for having me, Dr. Stracks. I'm really excited to be here. Really appreciate the opportunity. Can't wait to talk with you.
Good, me too. I am a big fan of your work, as you know, and I want to talk just at the beginning about how you got into this work. And so first of all, just what got you interested in the physical therapy field to begin with when you were first starting out?
Yeah, I had some excellent mentors really early, like coming out of college, that got me really excited about this idea that I could use my hands to fix the body, right? That there were these manual therapy techniques that I could use to do that. And I think because I had these early mentors, it just became a passion of mine to be able to do this with people. And I saw all these clinicians, doing amazing things and getting great outcomes. And I always liked to work with my hands. I always liked science. I was really into anatomy and biomechanics and physiology. And so it just kind of made sense. And then I had my own back injury actually about the same time, a big herniated disc that was diagnosed on MRI on my right side at L5S1. And the doctors wanted to do surgery at the time. And I was an aide and assistant in this physical therapy clinic. And so my journey really getting back well again was, can I avoid surgery? And then can I get pain-free and get back to being an athlete? And I had their help and their mentoring and some physicians that were open to not doing surgery. And that's when I discovered Dr. Sarno. So this was even before I got into physical therapy school. And so I only tell you that because I think it colored my early experience as a clinician that I then took through PT school and then brought into clinical practice. And so I always had this background of the body can heal, right? We can trust that. And I always brought sort of a hopeful, optimistic attitude into my session with people because I got to see it in myself. And while I didn't discover the mind-body medicine world until much later, I appreciate that I think that was one of the things that really helped a lot of my clients more than my manual therapy skills or my technical skills.
Yeah. And, as you and I were talking about a little bit earlier, I also had my own health experiences and brought this concept of the mind-body connection with me to medical school. And it's a very different perspective going through training, knowing about the connection than most physicians and probably most PTs who are more focused on just the physical aspect. And I consider myself really lucky that that happened so that I could sort of keep that perspective the whole way through rather than having to learn it at some point later on after some of the other material had been more sort of ingrained into my mind. So I'm really grateful for everything that I learned even before my formal training began.
For sure.
So you knew about this, you brought it with you to PT school. Did you start practicing in this integrated way right away? Like you sort of graduated from school, opened your clinic and started talking about the mind?
No, not at all. I think I always had like a little bit of a psychologically informed mindset, when I was treating people, but I was very much biomedical, biomechanical. I like to say I could explain anything I found through biomechanics. And the reality is if that made people feel safe and that gave them a clear explanation for what was going on, it's probably going to help, right? Because it reduces fear ultimately. But I was very much in that strict biomechanics mindset. I think I did, looking back, I think I did have these early therapeutic alliance skills and listening skills that we know are so important in this work as well. But I didn't have any of the clinical tools that you and I understand today. And so, I spent the first decade of my career working with athletes and other people in pain, thinking that I was somehow fixing the body, thinking that I was somehow intervening in a way that was helping a rib move better, or helping the pelvis, correcting a pelvic upslip, or reducing tension in the quadratus lumborum muscle, or improving the firing of a certain muscle to improve alignment of the leg. And I did medical bike fitting for a long time. I made custom orthotics for many years. And so the first decade, I say, is like my sort of really learning that stuff really well, before I then realized that I had to start to unlearn a lot of it to actually help people in a meaningful way in the long term.
Yeah. And so these days, now that you know all that and your practice has evolved, let's talk a little bit about what it looks like when somebody comes and sees you. And so you have your own practice in Boulder, correct? And it's been there for a while.
Yeah, I went through a number of like smaller private practice clinics where I worked as an orthopedic manual therapist, is how a lot of people hear it, for a long time. And then I started my own practice when I realized that the insurance companies were crunching physical therapy so much that we weren't really able to do a great job. And so it forced me to go into like a cash-based model where I could have the time to actually spend with people, and just feel like I was doing a good job, so I could feel good about it.
Yeah.
And so the last decade, the second decade has really been me. The gift of that is I get to create my own destiny. And I think that's what freed me up to be able to really explore this.
Yeah. And so somebody calls you and comes into your office, and they've got back pain or shoulder issue, and say they don't know you from anybody. You're the closest PT to their house. And so they walked in. How do you start to explain the role of the mind to them, to somebody who sort of thinks they're there for you to like teach them the right stretches and they're good to go from there?
Yeah, it's a great question. I think the most important thing that I try to do, and I try to teach clinicians, is to come into every client session with a beginner's mind, to not start thinking you already know what's going on. And I don't lead off with that. So I start with a subjective history that really is hearing the person's story, and that's a very emergent process. It's sort of like an ADHD collection of evidence over the course of 20 minutes, let's say. And in hearing their story, I'm starting to already collect evidence about what's going on with this person. But at that point, I'm not assuming that they have one thing or the other. I'm just really trying to listen to their story and asking them questions. And there are times when it's really clear, when things come up, or when they already have some openness, that I'll dive right in and start talking about the role of the brain and the nervous system in creating pain, if there's a level of openness. But let's say, as you said, they have back or shoulder pain and they don't know anything about the mind-body model. I might just do my subjective history and launch right into my objective exam, because that rule-out process is so important, as you know, for people regardless of where they fall on the continuum.
And I'm interested in sort of what you look for in a physical exam. And I know that it's interesting for the people who are listening, many of whom sort of haven't seen anybody who's psychologically informed. And sort of in these days of pandemic and telehealth, a lot of people sort of are getting care from people who've never actually met them in person. And so what are you looking for in the physical exam to try to help delineate which direction to go with people?
Yeah, my physical exam is still very much sort of orthopedic oriented, where I'm looking at range of motion, I'm testing muscle strength, I'm looking at positional dysfunction in the pelvis and the neck and the spine. I'm looking at all these things that I've looked at my whole career. But I'm sort of looking at them through a new lens. And especially if during the subjective history, I have enough evidence, there was no injury when the pain started. There was a definite life stressor when the pain started. We're seeing these symptom behaviors that we often correlate with primary pain or with brain nervous system driven pain. There are personality traits, as you know, that show up. And so if I have a lot of that going into my exam, I'll go into that with a little bit of a lens of, what am I going to find? What am I really going to find from this objective evaluation? And so I still go through all my tests though, and I still look at all these things. And what I try to come out with as I crunch all that information is there a pattern? Is there a clear biomechanical pattern that I can treat like I always have, especially in the absence of those other findings, those other bits of evidence in the subjective history? And if so, I might start there. Or do I come away with like a loose collection of normative findings that don't really coalesce into a pattern that's really treatable? And of course, we know that like things like scoliosis and leg length discrepancy and short muscles and weak muscles, those things are often normative and we don't have to worry about them. But as a physical therapist that was really trained to medicalize those and to think they're significant, I'm doing this like mental wrestling in my head of saying, do I need to worry about this or not? Is this really adding up to something that I can treat through the body, knowing that if we treat from the bottom up, that can be effective sometimes. And some people really like that. Mm-hmm. And I get this feedback all the time that, my evaluation might take 20 or 30 minutes. And people are like, I've never had someone evaluate me so thoroughly before. Like you left no stone unturned, right? Going through all this. And I'm explaining it as I do it, as I look at their neural tension and as I, look at their reflexes and their sensation and do a neurologic screen. Like I'm talking to them as I'm doing all this about what I'm seeing and what I'm not seeing. More importantly, what I'm ruling out, what's normal, what I'm impressed by, what looks great. And so it really is an opportunity to already start reducing fear a lot of the time.
Yeah. Do you know the statistics on how long it takes a physician to interrupt a patient who's giving them a history?
I thought it was like 8 or 10 seconds, but I think it's more like 20. I don't know what the number.
No, 7 seconds. 7 seconds.
7 seconds. Yeah.
Yeah. And I have had encounters where like a medical student was shadowing me and I've listened for maybe 3 minutes and the students have said, oh my goodness, I have never seen a physician listen that long before interrupting. It's the way the system works. I'm going to rewind you for just a second and talk about or ask you a little bit more about some of the findings that you see that you think are normative that people get told is either a problem or the source of their problem. Leg length discrepancy would be one example, scoliosis would be another. But can you talk a little bit more about that, sort of what you've seen and what you've learned about those kinds of physical exam findings over time?
Yeah, sure. I'll start at the end and just say most of the time, the physical findings that I see are either normal. People have had them their whole lives. Mm-hmm. So if you haven't had pain your whole life, then why are you having pain now? Because of that slight difference between the two sides. And I love the NOI group and Mosley and Butler talking about the fact that we grow like trees and mm-hmm. We're organic and trees are healthy, even though they have different branches on either side. And I have this cactus behind me that's crooked and broken and it's still super healthy. So I love that idea. But I also like to think of the findings as the result of pain instead of as the cause of pain. So mm-hmm. we know pain affects the way people move. We know it affects how confident they are in their bodies, how they inhabit their bodies. We know people are deconditioned, right? And so the brain in its state of danger alarm, in its fear state, is going to do things to create tissue change. It's going to reduce range of motion. It's going to take power away from muscles and they'll become inhibited. I call it inhibited rather than weak a lot of the time because it just is less scary, hopefully. So that's how I orient to these physical findings a lot of the time. Unless, someone's had surgery and they're recovering from surgery or I know they've had a physical injury and they need some support in, getting back to a normal level of function after that type of thing. In the absence of that, I tend to view it through the lens of this is the result of pain, not the cause, which is really backwards from how a lot of physical therapists learn.
And physicians too. I mean, clearly that physicians are taking sort of anything that walks into their office, and if they can make the correlation, will oftentimes sort of provide the causality there, even though it may just be a coincidence. I say to people, and I've probably said on this videocast series previously, when I'm meeting somebody new, the two major things I'm trying to do is understand, is there a physical issue that's so profound that if we don't treat it, the person's not going to get better. So a broken arm would be a prototype of that, right? I don't want anybody to break their arm, or I don't want anybody to come in with a broken arm and have me say, like, "I'll teach you this meditation, everything will be just fine." And then the other is that anything that's potentially dangerous to somebody, if we don't identify it and treat it, so that would be like a malignancy or an infection, or even sometimes autoimmune diseases, although there's some crossover with the immune system as well. And so that's kind of how I'm thinking about new patient evaluations. Are there things that you see that start to fall into that category? Are there things that you hear about or look at or feel that make you say, like, I really think that we need to take more of a physical approach here, at least at the beginning?
Yeah, certainly. I think if the pain, if the person's in the first healing phase after an injury that I can really identify, right? Like my wife broke her ankle 2 weeks ago, falling rock climbing, she's healing up, but you can see the phases of healing. So if I can tell that someone is in what we define as like normal tissue healing, like let's say a ligament takes 12 weeks to heal, and we know that that's reliable and predictable and we can count on it. If they're at week 8, then I'm going to be talking about the body and how great it is at healing, and let's support it, and let's do the things at this phase of healing that we know are going to be helpful. Yeah. The other time that I'll talk about the body really directly is if someone's deconditioned or they have adaptive change and they have things that I really feel are going to be barriers to them getting back and moving their body again. And of course, I'm not necessarily changing the tissue by touching it or sticking needles in it or manipulating it, but I'm giving input to the brain, and hopefully in a way that reduces fear, that feels safe to the person's nervous system. And the brain then creates that change from the top down because of my input. We know that emotions and safety and empathy and compassion can be transmitted through the hands into the body. So I rely on that sometimes, especially early in the process, as a way to say, hey, let's work on some of this stuff as you start to get moving again, and then we can move more into the psychosocial sphere, especially if people come in wanting that or expecting that. I'm not going to tell them, no, I'm not doing that for you, because it's not what you need.
Right.
Because that just increases fear and that makes them angry.
Yeah. Do you know our colleague? You must know our colleague, David Hanscom, out in San Francisco.
Of course. Yeah.
And, he really feels like so much of the therapeutic value is in creating a safe healing space with you or with me or with him or anybody in the health professions who can create that kind of safety for people. As you and I have been talking about, and as people listening know, too often the opposite happens. You enter into the medical system and you just get more and more scared. But I say with some regularity, I want to take my yoga instructor colleagues and have them teach my physician colleagues just how to interact with people, how to say, hello, how are you? Nice to meet you. I'm sorry you're not feeling well. And it seems so simple and ludicrous when I say it. And yet I hear story after story after story of people entering in the medical system and being dismissed, being treated poorly, but certainly not finding somebody who they feel like they can partner with to create some of that safety. And it makes me sad that that isn't front and center in medical training.
I agree. It really is the foundation for everything else. And I think it is hard to teach compared to like the technical skills, the clinical skills that we use to help people with pain, the mind-body skills. Those EQ skills, emotional quotient skills are really important, and they're hard to learn and hard to teach. But I agree, they're the foundation for everything else.
Yeah. Back to the physical for a sec. Do you ever either look at images or order images after you've seen somebody? People obviously will come into me a lot, having had lots of CT scans, MRIs, X-rays, and sometimes wanting to know if they need more. What's your experience with that? How much stock do you put in what you're seeing on imaging?
Yeah, it's a great question. I just spent some time like crunching all the research into a document about not just the spine, but the shoulder and the knee and the ankle and the foot. And we have a lot of studies that are similar to that original Brinjiki spine study, talking about that those findings are normative, right? So I review a lot of people's scans because, as you said, they come in already loaded with those, and I go over those with them, and then I correlate that or not with my objective findings, and that's really important for me to feel safe to be able to tell someone that they're okay. Versus sometimes I refer people out, and then I rely on my physician partners, especially the orthopedists that I work closely with, to be able to look for a stress fracture in a runner, for instance, or to rule something out that's insidious. And I have this pyramid that has like levels of evidence, and at the bottom it's like RCTs and all these different types of studies, research studies. And at the top of the pyramid is I just know. It's like an intuition. So after 20 years, you have some experience being able to say, this person's an outlier. I can see it. Sometimes there's a physical symptom that doesn't make sense. Sometimes it's the testing that you do that you're like, this just isn't adding up to what, to either a clear body biomechanical thing or a mind, brain, nervous system thing. And so I really want them to go get looked at. I just sent someone this week to see a cardiologist, for instance. I send people to the orthopedist all the time, and then I rely on them to be able to feed back to me what they learn. Because again, I need to feel safe as a clinician to be able to help people go down this new road. And there are times people need surgery, and surgeons are really good at doing that. So I'm not closed off to that at all by any means.
Yeah, and I think that I talk with a lot of people, obviously, in this world, and everybody's sort of trying to figure out how to put mind and body together, how much stock to put on the mind side, how much stock to put on the body side. None of us are perfect, and so it's not that sort of it's either this or that. But I think you and I are trying to put together the best story that we can to then try and provide people with the best combination of therapies that's going to get them feeling well as soon as possible.
And there are a lot of people, right, as you know, who don't know. They're in the gray area, and even the physician can't tell you with clarity. We learn this is like a binary or some dualistic, like it's either this or this. And the people in the gray, are more challenging because you have to create enough openness that they're willing to wait and see. Like you can tell them, like, this isn't an emergency. We don't have to do this now. You don't have to intervene or do anything now. Let's just give it a month and wait and see. And then, surprisingly, over the course of a month, they get totally better. And then right?
Right.
Retrospect. Yeah. In retrospect.
We did a interview in December, so it was before the holidays, with a woman named Laura Burke. You know.
Oh, I know Laura, of course.
Yeah. And Laura has had 16 surgeries on her legs over a 30-year time period. And one of the things we talked about in the interview is she was in one of the curable groups as a participant. Now she's a leader, and she said to me, I've had 16 surgeries. Like, how is this relevant for me? And I gave her the answer that I always give, which is that there's always a physical component, there's always a psychological component, there's always an emotional component. It turns out that in my experience, and probably yours, the psychological and the emotional components are much larger aspects of the whole picture than we would have known, because intuitively you think it's all a physical issue. And so what I said to Laura was, get started on the psychological and emotional side. And, if it's 50-50 and you get 50% better that way, is that worth it to you? And it turned out she got about 90% better that way. And it freed her up not to have to know the difference, and just to sort of do the work over here and see where it led to. And she obviously had a lot of physicians and physical clinicians looking at her over the years. And so she was comfortable that like nothing else was being missed, and she was being told by people that nothing else was being missed. But when she stopped sort of having to decide ahead of time what was what, that allowed her to soar into the places where she is now 3 or 4 years down the road.
Yeah. Amazing.
And so how do you get started with people? And so you've done the evaluation, you've talked with them. It sounds like sometimes you go a little bit more down the physical route. Sometimes you're incorporating the emotional side right from the beginning. But what kinds of things do you work on with people over the course of a treatment with them?
Like let's say on the first session or on
Yeah,
follow.
or even sort of on an ongoing basis if you're seeing somebody 3 or 4 or 15 times.
So I always and I teach clinicians this too. I always come away with like a short list of body oriented things that I think might be important, and then a list of more brain, nervous system, psychosocial factors that I think might be important. And I like to present those to people and talk about them in a way that reduces fear and normalizes them. And just to show the person that, you know, these are all easy to treat. I can show you how to do it. A lot of people can do it themselves, and really empower them to run with that. And that, because I'm presenting both of them, it sort of frees me up to then be able to talk very specifically about the psychosocial parts, especially if I feel like they're the most important factors to treat. And as you know, they usually are. Like 8 or 9 out of 10 of my people, even though I'm in Boulder, Colorado, like one of the most active towns in the country, and even though I'm getting a lot of, you know, active athletic people really early in the pain cycle, right, in the first days or weeks, 9 times out of 10, we're still starting with the brain and nervous system. So, so yeah, I just launch right into my psychoeducation, a lot of which I learned through you know, this mind-body world that we live in, but also through Mosley and Butler, who have an excellent, you know, Explain Pain program that really does the psychoeducation justice. And I've sort of synthesized those things. And I always say that my psychoeducation is really an act of improvisation, and I don't have like a script. And I just, depending on the person, I just go in and share what I feel like needs to be shared, but in a way that's going to resonate the most for them and is going to couch it in their context, right? So that I'm not just generally sharing the science, right? I want it to be a conversation, a dialogue between us, not a lecture. And I want it to make sense in their context. So I'll use metaphors that relate to an athlete or a lawyer or, you know, whoever the person is.
Yeah. What kinds of psychologically based interventions will you hand out? And so I can picture in my mind as a physical therapist, you know, do these stretches or these strengthening exercises, or let me show you sort of how to hold your posture in this way, or sort of the variety of things that we stereotypically think of in terms of physical therapy, and you may be doing other things on a physical level. But what kinds of assignments will you give people on the psychological and emotional level as you're working with them?
Yeah. So first, the physical stuff I orient to as a performance opportunity. This is a way for you to remove any barriers that might keep you from getting back to running or squatting or, you know, whatever your goals are, your physical goals. And I talk about it as though it's a way to have a conversation with the nervous system to create some change, right? We want to have a conversation with the brain, so it will allow your hip to move more, or it will allow your ankle to move differently, or it will allow your muscle to kind of come back online, and these things that are the results of pain. And so, yeah, we can do that justice sometimes. And then, you know, like the first step in the process is starting to help people shift belief and understand what pain is and how it works. And then there's a like building an evidence list phase. And so I'll go over with people the evidence that I have against the body. I'll talk about the things that I didn't find during my exam, and how great everything looks, you know, in a lot of cases, and how we have these little opportunities, but really overall you're looking, you know, your body looks great. There's nothing wrong with your body, essentially. And then I'll talk about the evidence for the brain and nervous system, assuming people are open. And I'll go over that with people, symptom behavior, and that leads to a lot of really interesting conversations. And that's when you really get a sense for if people have any doubts or cognitive dissonance, or, you know, things they're unsure about that you need to clarify. And then, you know, once you're through that, then you get right to what I sort of lay out for people is we have the option to do this through the body and through movement to reduce fear, right? But we also have the ability to do things like somatic tracking, which is start to reconceptualize what the pain means and start to observe pain in a new way, or start to track our thoughts and our feelings around pain. How often during the day do we go to danger thoughts, and what are the things that come up? Are you thinking about the fact that you're getting old all the time? Like we can both do that CBT-ish type work, but also help people observe the symptoms in a new way with curiosity. Or we can go down this more emotional road of saying all these things that came up during the exam, both your fear of the pain itself or your emotions about, how long you've been in pain and your experience with the medical system and whatever else has changed in their life because they've been in pain, or the other emotional stresses that are due to just life change or past hard experiences, right? These things are psychosocial factors that people would never connect to pain.
Right.
In my clinic, it may be the first time they're hearing this.
Yeah.
And so I lay this menu out. I say, what resonates more for you today? Because not everybody wants to talk about emotions right away, especially when they come in to see a PT.
Right.
They say, I'm having plantar fasciitis, Charlie. Like, can you fix it for me?
Yeah.
I may not start with the fact that, they still have these big emotions about the fact that their kids are struggling in school. I might start with the body even, and then gradually over time titrate in these other tools. Does that make sense?
Yeah, and especially, you're a physical therapist, and so people, even when they understand or are coming to you because they know there's a mind component, it's still, I think, more comforting oftentimes for people to feel like they're addressing the physical aspect of what's going on. And so it totally makes sense to be able to start there before delving into some of the deeper emotional side. And, you and I had both learned about this very early on from Dr. John Sarno, who people don't know is one of the very early pioneers in this field, practiced in New York City in the 20th century. And, I spent some time with him when I was training. And what I was struck with most was the fact that he was a physician, but really thought like a psychologist. And that's what you're describing, right? You trained in physical therapy, but you have all these skills and abilities on the psychological side that can make people feel held in both places, which is great. And I think a lot of people who end up doing a lot of work in this field feel comfortable on both sides of the equation, that very skilled on the physical side, but you're describing an ability to really be with people on the emotional side too, which is fantastic.
For the physical therapist that might just be learning about this, it's been a journey of sort of building courage over time. Howard Schubiner had to give me permission to do this to start. And then, I had a lot of fear about it at first. And so I had to gradually explore it. And the more I had success, the more confident I got. And now I'm to the point where I feel like, if you're not treating those things, then really pain is outside of your scope of practice. You really can't treat pain without those things. Yeah. And so PTs will ask, should I be doing this? Am I allowed? Can I do this? Can I get out of my silo? I'm like, well, if you don't, you can't treat pain.
Yeah. And somebody said to me recently that they were told by somebody in the medical system somewhere that they're going to have pain for the rest of their lives. And I said, with probably more of an edge than I should have, if anybody tells you that, they don't understand, they don't fundamentally understand about pain. And to think in this day and age, right, mid 21st century, that people still have in their mind that these things are not changeable, that the nervous system doesn't have the ability to move towards health, it's just a fundamental misunderstanding of the science at this point.
Yeah, for sure. Sure. And I do want to say, like, I'm realizing that as I've been more immersed outside of my own profession in the mind-body world with these amazing people like you and other physicians who I really respect, I'm realizing there's this like missed opportunity. If people want to talk about the body, people want to talk to us about the body, and they want to trust that we understand the body. So we can't just say, hey, leave that behind. Your body's fine. Let's just move on and talk about your emotions now. Yeah. People still want a certain amount of that. We just have to be really careful about how we do it. And that also has been a journey for me of like, how do I really do this with fidelity in my practice and not scare people?
Yeah. And so along those lines, one of the biggest questions that I get asked is about getting back to activity. And so as people are learning about this, many people who are listening and who have symptoms have stopped running, walking, sitting, working, being with family. And so the question is always, how do they get back to doing the things that they want to do in a safe and effective way, which I personally find to be one of the more difficult aspects of all of this, is sort of moving forward, knowing that it's not a straight line and it's not necessarily oftentimes you move forward and there are setbacks along the way. And so how do you help people move into a place where they're now comfortable doing the activities that they've had to stop while they've been having symptoms?
Yeah, it's a great question. I mean, ruling out the body, of course, is the first step for people. So if I haven't established some type of rule out and given people confidence, then it's hard for me to give them the green light to start doing things, which I try to do most of the time. I mean, we know that if people tend to get worse when they stop engaging in movement, right? And so almost universally, I go beyond I need to get you back moving, as a starting point, to movement is actually the way that you're going to get better. There's no reason to avoid movement anymore. And the way I think physical therapists have an advantage is then we can, in a really skilled way, help to support people in feeling safe to do these things again. And that might mean cueing them to do something in a way that they hadn't tried before, which is kind of just a brain trick to be able to create a new neural pathway based on novelty and something the nervous system doesn't recognize as dangerous. If a physical therapist is saying while you squat, hey, I want you to hinge from your hips, make that how you initiate the squat, because we want to put the hips in charge. And I want you to drive your knees out, because I want to make sure that, your knees are in the right position. I don't always say it that way, because then it suggests that biomechanics are important, which they maybe aren't. Yeah. But, I'm cueing people to do things in this new way where they start to feel safe. And then they're surprised and they're like, wow, I can do that. I'm so surprised I could do that. And then they get to leave with something that they're really excited about.
Right.
So what I see is that when people try to engage in graded exposure in the old model of not thinking that their body's okay, it doesn't tend to go very well. And if they can do the same graded exposure process with this new mindset, with this new belief, it can be a totally different outcome. They can have much more success and blast right through their old barriers they had before. Yeah, I think I'll pause there. Does that answer your question?
Yeah, and then the continuation of the question is, how do you reassure people, say, they see you guys have a good session, it feels like a breakthrough, and then they come back the next week and said, I felt so good, and I went out and I ran half a mile, and I was in bed for 3 days afterwards. And so how do you coach people through some of the moving forward and feeling like they're having a setback?
Yeah, it's a good question. I lean back on my explain pain training, honestly, for some of that, because there are some great visuals and great psychoed pieces about how pain doesn't mean you're doing tissue damage. And in fact, you have to go into some amount of pain over and over and over again and reinforce for yourself that you're safe to have success. If you avoid pain, you'll stay in the same situation. Similarly, if you get to a point of flare-up, you still haven't done tissue damage most of the time. But you triggered your nervous system back into this danger alarm, and it's going to be okay. And we'll work through it. And of course, we're always trying to find what's the sweet spot. And that's a moving target for me, because someone's like, Charlie, how much should I run the first time? How should I do this? I'm like, I could guess. Right. I really want to empower people to know that some amount of discomfort is normal and okay and expected and needed. And then they can be their best barometer of what they need to do on a given day. If they've had a really stressful day at work, they may have to do a little less. If they're feeling really good and it's a nice day and they're with a friend that they love, they may be surprised and they may, get away with something that they never thought they could do.
Yeah, I'm a big Mosley and Butler fan as well. The Explain Pain series is great. The professional version of it is fantastic. I've taken a couple of their trainings as well. And I really do like their model of thinking, like, what can you do where you know that you're going to be okay? You can walk around a block. Or for some people, like, you can walk to the end of the driveway. What do you do that you know would be too much? Run a marathon tomorrow. And so, okay, so now we have a sense of where you can push your edge and what would be absolutely too much. And let's try to stay in that area and gradually lift it up. And so raise the ceiling, keeping in mind, or raise the floor, keeping in mind where the ceiling might be. And I think that's a helpful visual for people. And it still has some uncertainty to it, right? Can we guarantee that you're not going to sort of push over the edge and then be back in bed for a week? But I try to normalize that as well. Okay, things got triggered again. You pushed harder than your body could handle in this moment. Good for you for doing that, but it doesn't mean that you did more damage. It's just, this is a temporary setback. We need to continue to slowly raise that area where you can safely be active.
Yeah, for sure. That's a great point. And I do rely a lot, as sort of a movement oriented person, I rely a lot on things like novelty and play and being in nature and changing the rules about things to trick the brain and nervous system into not recognizing that something dangerous is happening. Because once the person has created a conditioned response through predictive coding, they've paired, for instance, that running in this situation is dangerous, so they have pain when they do it. Sneaky thing the brain does, right? If I can change the rules and I can bring some novelty into it and I can make it fun and playful, it tends to really have change the outcome. And people, again, are often really surprised that they can do as much as they can when there's novelty. And our nervous systems are wired for novelty. And if we're continuing to try to do the same thing, I'm just trying to get back to running and running and running and running, the brain's like, nope, you need something different. So what are we going to do to create novelty? Maybe it's different terrain. Maybe it's, listening to music. Maybe it's doing it with a group or with some friends. Maybe it's doing a different sport for a little while, mixing it up. Maybe that's what the brain wants.
Yeah, absolutely. We talked a lot about sort of, again, sort of stereotypical PT clients, back pain, neck pain, shoulders, joints. Do you have much experience with people with sort of wider ranging pain syndromes like fibromyalgia or CRPS, where it's not just one area of the body that's in pain, but sort of everywhere or sort of one area that's significantly symptomatic in CRPS with swelling and heat and color and skin color changes? Is that part of your practice at all? Do you do any work in those areas, or have you over time?
It's a good question. I'd say more and more as I've gotten more into this work. It's definitely not the majority of my practice, but I do get people with chronic fatigue symptoms or fibromyalgia or symptoms that I've never seen before. The brain can produce any symptom it wants, and so people will show up on my schedule that have the wildest symptoms. And multiple symptoms. So one whole side of the body, or a whole leg, or a whole arm, or cyclists end up in this situation a lot where like all their stuff is on one side, and they have 5 different, they have 5 different pain areas. That stuff I see all the time. And I think what's interesting is like swelling, as you said with CRPS, swelling is like the most scary symptom for people, because different from pain, which is invisible, which makes it challenging socially and psychologically in its own way. Swelling you can see. And so people say, oh, I have swelling. Well, there must be something wrong because I can see it and I can touch it. Well, it turns out swelling is like any symptom. It can show, the brain can turn on swelling anytime it wants to try to get an athlete's attention. And so this is why catching this stuff early in the acute part of the cycle of pain can be really helpful to just normalize for people. I know your pain just started yesterday or last week, but it doesn't necessarily mean you're injured. Your brain is doing this thing, producing swelling. So to go back to your question, CRPS, fibromyalgia, I see a little bit of that. Those are definitely the more challenging conditions to treat, as you know. I'd be curious your experience, your success with CRPS, for instance.
Yeah. Yeah, I think that, there's a lot of evidence these days that the immune system and the nervous system aren't separate. They're actually one neuroimmune system. Mm-hmm. And so we start to think about it that way. And then all of a sudden it makes a lot more sense. If our nervous system is revved up, then our immune system is revved up too. And so we have a patient in our practice with rheumatoid arthritis, a prototype autoimmune disease, whose inflammation scores have gone down by half by working with one of our psychologists. And so like she hasn't done any additional physical treatments on any level, but her immune system has calmed down as her nervous system has calmed down. And so that I think is helpful for people to keep in mind. I've got another patient who I interviewed in this series about 1.5 years ago, who had a catastrophic leg fracture playing basketball in 8th grade-ish, high school, somewhere in there, and had significant swelling and redness and skin changes and pain, and has done just phenomenally well over the last number of years by understanding all the nervous system components to these immune system symptoms that he sees in his body. And so when I see somebody with CRPS, and we've had a fair amount of patients who have done well with it, I normally conceptualize it in my mind and sometimes say to people, I don't think it's any different than anything else that we're talking about. I don't think it's different than somebody who comes in with ankle pain without any swelling or anything else. I think oftentimes it's a little bit more complicated, and oftentimes there's a little bit more in the background that needs to get worked out. But I think that the process is the same. And so if people can stick with it and really work on calming their nervous system and creating safety with movement, I've seen people do really well with those kinds of symptoms. And it's like we were saying earlier, people will tell me, right? They were diagnosed with CRPS, so they went home and they Googled it and they're like, I'm dead. Like there's nothing that I can do about this. And again, it's a fundamental misunderstanding of what we know about the human body at this point, which is that sort of gently pushing people to move forward while we're helping them to create safety and calm their nervous system down, then our bodies will respond ultimately to that sense of safety, and people can get back doing what they want to do.
And I love that you called that out, that all the systems are communicating, the musculoskeletal and the nervous system, the endocrine system, the cardiovascular system, and the immune system are all different, outputs the brain has, different systems the brain can affect. Mm-hmm. So people talk about heart rate variability with POTS or, these other conditions that we now know are more sort of on the mind-body side of the spectrum. We start to reconceptualize then how we're looking at those things. I've had people that have come in having recovered from CRPS in one body part, and then they have CRPS in a new body part. Mm-hmm. And despite the fact that we're starting to explain this from like a autonomic nervous system perspective or an immune perspective, there's still resistance to that because it's hard to learn when we're in pain. Pain really massively affects our lives in significant ways. As you said, there's often some strong psychological and social layers underneath that really need to be addressed. But I think most importantly, it's just that it's hard for people to believe that they could be in so much pain. Mm-hmm. Right? And even when they've seen it before, and that they can get better.
Yeah, it's hard for people to believe that. It's hard for practitioners to believe that as well. And so I may have even said this earlier, but if we had 100 physicians in this conversation with us right now, I think 98 or 99 of them would say, like, yeah, if the pain's that severe, it means something is severely wrong in the body. But the research clearly doesn't support that, right? Pain is one thing, tissue damage is another. There's some overlap, but they're not the same concept. And there you can get plenty of pain without tissue damage, and interestingly, plenty of tissue damage without pain. also. And so we can't go into it thinking that those are the same things, because the research clearly shows.
Yeah, it's hard to believe. And there's a lot of attachment by clinicians, and there's a lot of attachment by patients to this sort of old narrative, this old model. Like in my profession, people are talking about breathing a lot. They're talking about like breathing being dysfunctional or being broken, or need to intervene with breathing. And you and I, though, know that breathing is just a reflex. We're not choosing how to breathe. Breathing is a manifestation of how safe the organism feels, right? So if you can shift that, then the breathing will take care of itself. So instead of pathologizing breathing, let's look at it as a result of a nervous system that's in a state of danger alarm. And we can talk about the vagus nerve all day, but the vagus nerve is controlled by the brain. So
yeah. Do you know Dr. Clausen up in Seattle at all? A colleague of Dr. Hanscom's, and they just put on a conference about the neuroscience of pain a couple of weeks ago. And so I've been listening to their talks. I like DR a lot. And he said that he doesn't use the word stress very often when he's talking with patients, because his research has shown him that stress is the response to threat. And so stress isn't the primary issue. Threat is the primary issue. And then the stress response is our appropriate response to feeling under siege. And I really like that model a lot, because people get shamed by saying like, oh, I'm so stressed, or I can't know how to deal with it. And it's not, the stress is actually our body trying to deal with the situation. The threat or feeling like we're in danger is where the problem develops.
Yeah, it's interesting you say that. Like people in my practice really don't like the word fear. I think there's like a leftover. Remember that marketing campaign, the no fear marketing campaign to like the 80s or 90s? I think there's like some remnant resistance to like people acknowledging that they have fear, right? Of course, we all have fear. We're living with fear all the time. And I like that you said it's the situation. Like we don't need to talk about stress or fear, label it. Like it's our life situation that we're all living with all the time. I normalize this to the end of time. You know, I talk about how it shows up in me. I talk about how it shows up in my wife with her broken ankle. 2 weeks in, she has psychosocial things that are really affecting her healing and her pain. And so I just like to talk about this being a normal human experience, as opposed to like making it a diagnosis. You know?
Absolutely. In the time we have left, I want to shift gears just a little bit and talk about some of the professional teaching that you do. You and Dr. Schubiner have had a series of classes that you've taught. How has that part evolved for you? At what point did you recognize that you wanted to make that part of what you were doing and part of your contribution to this field?
Yeah, I mean, my teaching for me is so meaningful, because as someone that's worked alone in my practice for so long, I felt like I had an obligation to scale and really share what I was doing, you know, in a larger sense at this point in my career. And so the best way to learn something is to teach it. And so I think part of my confidence over time has come from sharing this with other clinicians and teaching other clinicians. And I want to support my colleagues in unlearning the things they need to unlearn. And then more importantly, learning these new skills to be able to bring them out into the world. And I really appreciate, you know, I just like so much gratitude to be able to do this with Dr. Schubiner and the confidence he brings into the room. I've learned so much over time, you know, and continue to. And as our course has a consultation component afterwards, where we continue to every month get together and talk about cases and learn skills and review things. And, you know, different from the like train and hope model that I grew up with. It's like, here's your weekend course, like, good luck. I continue to learn and they continue to learn, and it's just very rich.
Yeah. What kinds of misinformation do they bring with you? What do you find that people have learned in their training or in their experience that is counterproductive in working with patients?
You mean the physical therapists that I train, or the chiropractors or body-oriented clinicians? I mean, it's interesting because a lot of the clinicians don't sign up for the course unless they already have some orientation in this direction. So they're already coming in with some amount of openness to these ideas. There are still, the majority of my colleagues are very attached to the old ideas, and I see it on social media all the time, and I see people talking about it on YouTube. Those people aren't the ones signing up for my course. They'll resist that to the end of time, because it threatens their identity and it threatens everything they know. But the reality is a lot of these clinicians are having to unlearn a lot of what they learned in PT school. I've had students that are either just graduating PT school and are still students, or in their first year out of school, and they're just shocked at how different this way of thinking is based on what they learned in school.
Mm-hmm.
And because there's openness to that, they're very quick to be able to move in this new direction.
Mm-hmm.
But yeah, they're armed with like posture's important, and we need to get people strong. Like somehow strength correlates with pain, which we know it doesn't. And even mobility, like these things are factors, but they don't correlate the way we thought they did.
Right.
And so, yeah, people have to really come into this course with a real openness to even starting to get curious about whether that's true or not.
Yeah. And as you said, a lot of people are coming with that curiosity already developed. We've hired 3 psychotherapists and working on a 4th to work with us in our practice over the past year. And they're all here in our office because they're interested in being able to cross these boundaries. But it's interesting, psychotherapists learn about the mind, and many psychotherapists don't feel like they have the right or the understanding to work on the physical pain side. And so it's incredible to see all these people in these various camps being brave enough to start to move into the other side and be able to say, like, yes, I trained as a physical therapist, but it doesn't mean that I can't ask you questions about my lives. And these psychotherapists say, like, yes, I'm very good at asking you about your life, and I'm becoming more comfortable at saying, tell me a little bit more about what's going on in your body. And one of the harder parts, I think, for our therapists is being able to say, I don't think you're injured. I don't think you need to sort of have another examination. I think that you can do more physically than you're worried that you can. And so it's amazing to see people who are finding that they can cross over into these sides and do this integrated work that is what everybody needs.
Yeah, it is. I have a dream of being able to work with psychotherapists to get more confident in that skill of even teaching people movement. Mm-hmm. And developing the skills to really show people that their body's okay, like show them, not just tell them, but be able to show them.
Yeah.
Of course, you and I have the ability to touch people, which is a real advantage for lots of reasons. And there's no substitute for getting your hands on someone and then being able to say you're okay. There's nothing wrong with your body.
Yeah, I agree with that. And, and I think it too, you and I sat on a panel together a month or 2 ago at a conference, and the question came up about, like, how quickly is this field expanding? And what I said, which I think is true, is that 13 years ago, 2009, Dr. Schubiner and I invited everybody who we could find in this field to come to Ann Arbor, Michigan for a day and share ideas and get to know each other. And 30 people came, which was amazing. And Dr. Sarno videoed himself in from New York City because he couldn't travel. And it was fantastic. And now Curable has a Facebook group for clinicians, and there are literally thousands of people around the world who are interested in this. And so over the course of the decade, interest in doing this has grown at least 100-fold, if not more. And you and Dr. Schubiner, me and Dr. Hanska, like all of us continue to work on figuring out how to spread the word, how to explain it to more people, how to get more people comfortable understanding people and the medical profession as integrated together and not siloed into this specialty or that specialty. And it's an incredibly exciting time to be doing this.
It is. It's a massive paradigm shift, and I hope it's going to significantly interrupt the status quo for time. And yeah, I agree with you. I feel like watching this exponential growth is extremely exciting.
Yeah.
Really. And I'll just say, I think that physical therapists are really well positioned to do this work as like a frontline provider, and especially to be able to catch this early before it tips into chronicity and tell the person with, 3-day-old back pain or brand new plantar fascia pain, in the case of like a runner, let's say, that they don't have what they think they have, what their friends are telling them and what their doctors are telling them. They actually don't have a body problem. They have pain for all the reasons that you and I talk about, for these other psychosocial reasons. And if we can catch that really early, especially with the support of our like physician colleagues, if you have like really good people around you to back you up, I think PTs are in a really good place to be able to do this work in the future. So
yeah, we were approached by a young PT here in Chicago about potentially doing some work with us moving forward, and he described sort of, despite only being a couple of years out of school, having some outcomes that some of the orthos that he works with are surprised about. And he's clear that like he doesn't have the like physical manual skills that are beyond his years, but he's good at sort of sitting with people and asking them questions and making them feel safe. And all of a sudden these people are finding outcomes that they haven't been able to find in other places. And I can't tell you how many times over the years I've heard from physical therapists or massage therapists or hairdressers or just people who find themselves being able to talk with people and listen to the story and not be judgmental. And what an incredible difference it makes in the lives of people, in addition to all the professional skills that they've cultivated over time and bring with them.
For sure. And I think these young physical therapists having more like the beginner's mindset and not having had so much, continuing education and experience reinforcing the old way, I think they have especially have an advantage to being able to do this work really well. And the young clinicians that have come through our course have just blown me away with how effective they can be in the clinic. And as importantly, because a lot of my colleagues are really burned out, especially working in the old model, they're loving what they're doing. They're absolutely loving the work because they're changing people's lives, and it's so meaningful,
Yeah. I have a lot of hope for generations that are coming up who are just more comfortable in the emotional world in general. And so not unusual that I see a young millennial or somebody in Generation Z and start to talk about the mind-body connection. And they're like, duh, like, why would somebody not think that? And so that actually gives me a lot of hope as well. Before we sign off, any other last thoughts, especially for people, and there are a lot of people listening who have been working on this for a long time and either haven't made much progress or aren't making the kind of progress that they would like? Any last thoughts on how to help people who are pushing and understanding and educating and still feel stuck in what they're doing?
Yeah, that's a great question. I'm so glad you asked that right at the end here. I have so many ideas on this. I think the most important one is the process is not about working harder and trying harder, right? You have to sort of support people in actually trying less hard sometimes, because the harder you're working at it, the more you're trying to get it to go away. It's so paradoxical, right? Outcome independence. Like the goal is not to get the pain to go away. So hard for clinicians and patients. So when people have gone through Dr. Schubiner's book 3 times and filled it out 3 times, that's not going to be what helps. As a physical therapist, I had the fortune of seeing people, I may have been their 3rd or 4th PT, and they've tried all these other things and they haven't worked. And so I have the advantage of saying, well, okay, we know what hasn't worked. So now what are we going to do? Like, we're not out of ideas. And similar with the mind-body world, when people come in and they've tried all these things, it's helpful as a clinician to work with them to identify, okay, what haven't you tried yet? You've tried all these things, maybe they helped at the time, they're probably great strategies, but right now, what does your brain and nervous system need? And what have we missed, right? What have we missed? And let's simplify it, boil it down so it's less overwhelming, and help people be able to really focus on doing that thing really well.
Yeah. And I especially like what you said about, this concept of trying softer, which sort of doesn't, like, that concept doesn't really exist in our culture. And yet that's oftentimes what people need. And I've started to learn just a little bit more about acceptance and commitment therapy, with this idea of anything that we don't want is ours to keep until we don't not want it anymore. And it's such a paradox, right? It's such a and the idea that we do these things because they're important and not to make the pain go away, because that's what we want, right? We want to live our life without the symptoms.
Of course.
And yet somehow if we focus on that, the symptoms are more likely to stick around and not disappear.
Yeah, it's really challenging. It's really challenging. And every person has a little bit of a different need. And it's important to be able to show them over time in their own context what's going to be the most effective for them. So it's what I love most about the work is that problem solving. It's always been my favorite part of the whole process.
Absolutely. And I think, the last thing that I'll say just about people being stuck is that, there's a fair amount of examples out there of people who get better really quickly, right? People who read Dr. Schubiner's book and then they're better.
The book.
Yeah. And it turns out that there's a lot of people out there who have really struggled with these concepts for a long time. And we've tried to interview patients in this program who have taken, 3 years, 5 years, longer to really wend their way forward and have taken very uneven routes. And so a lot of times people will say to me, like, it's just, I've been working on this for so long. And in the context of what I've seen, it's actually not that long of a time frame. And then another thing that I've been saying to a lot of people lately is they'll ask me, like, when am I going to get better? And I say, you're getting confused and thinking that better is a place, because better is a process. And when we look at it as a process, all those people who are asking me when they're going to get better already are better. They're not necessarily where they want to be, but they're not where they started either. And if we miss that part, if we miss the process, then we keep thinking we're supposed to be somewhere where we're not, and we miss all the amazing things that people have done to really start to move the needle for themselves.
It's a great point. It's like, let's look at how far you've come instead of how far you have to go. That reframe is really important. I also like the idea that someone told this to me one time, that pain burns out like a campfire. Like you never see it burn out. It just happens in the course of you setting new boundaries in your life and creating new patterns and reminding yourself you're safe 1,000 times and starting to move again with joy. It happened almost by accident. And one day you're like, oh, I don't know. I never saw it happen.
It always happens in retrospect. And you're like, oh, it's a bad day. I haven't had a bad day in so long. Or somebody else will say, oh, you've been talking for 2 hours. You haven't mentioned pain or symptoms at all. And that's what getting better looks like. Anything else? Any other thoughts you want to add before we sign off?
Oh man, we could talk about this all day. I've been talking about it all week, and here we are on Saturday, and I could just talk about it with you all day. I'm so excited about it. I have so much energy about it, and I want everyone to know about it. Shout it from the rooftops.
Absolutely. So thank you so much. We're going to end there for the evening. I so appreciate your being here and sharing your experience and wisdom and examples. And so thank you for being here with me for this hour.
You too, John. Thank you for all the work you do, and for collaborating at times, and for sharing this podcast. And absolutely. It takes a village, doesn't it?
It is. And thank you to everybody who's listening too. It's every time we do this, I'm just reminded how brave and cutting edge so many, literally millions of people around the world are in working on their symptoms and going at it this way, rather than defaulting to outdated models of what pain and symptoms are about. As I said earlier, we've been able to expand our telehealth options during COVID and beyond. And so anybody who's interested in consulting with me or one of our staff members, you can go to our website, www.drstracks.com, and our staff will get back to you with the details that you need to know. If you're interested in Charlie and his work, you can go to his website, which is, Charlie?
It's the letter M, performance.com, mperformance.com.
Great.
And I will just say that my work going forward is also about supporting athletes and the audience that's not really getting this message is really sort of my next step here, is spreading that to new populations. Yeah. And that's what I treat in my practice. So if you're an athlete, please reach out.
Great. You can find this recording after the fact and all our previous episode at Curable and My Hope for Healing landing page at curablehealth.com/hope for healing. You can sign up for our office newsletter there and get all kinds of updates about upcoming talks and events. And with that, we'll sign off. Good night, everybody. And everybody, please stay safe and healthy.
Thank you. Bye, everyone.
Thanks, Charlie.
Thanks, Dr. Stracks.